Welcome back to 90 Day Dental, day 54. So we finished another topic and we're starting a brand new one today. And it's a really interesting one because this isn't a very typical topic that gets done very often, but it's also a very, very interesting one that a lot of us probably need to know and understand a lot more about moving forward. So we're going to be concentrating on special care dentistry, which is on a three-parter delivered by none other than Natalie Bradley, who's an exceptional speaker, but also really passionate, and hopefully that comes through in all of her messages. Really excited and looking forward to this, as she is one of the best speakers I've had the pleasure of meeting.
So firstly today I'm going to be talking about capacity assessments and consent. The reason why this is really important is we need to treat our patients as individuals. So I want you to do an exercise for me. I want you to imagine you are a patient for once. I want you to imagine you walking into a dental surgery and sitting in the dental chair. But instead of talking to you, the dentist who's treating you talks to whoever you've come with. That might be your wife, your husband, your carer. You understand everything your dentist is saying. Maybe you just need a little bit more time to compute that, or a little bit more time to communicate that. Or you need someone to help you use sign or pictures to help communicate that you understand. How do you feel that dentist isn't talking to you? They assume you don't understand, they talk over you and talk to whoever you've come with. This is why it's so important that we don't make judgments about patients and actually reassess them as individuals each time they come to see us. So the patient groups that we worry about in terms of whether they might not have capacity to consent include patients who might have degenerative or cognitive problems like dementia or Alzheimer's. They might have a learning disability, so they might have Down syndrome. They might have autism, for example. They might have a mental health problem, so they might have schizophrenia. They might have personality disorder or bipolar. They might also be patients who might be alcoholics or substance misuse, and they might be intoxicated. Also think about patients who might have brain injuries, so they might have had a stroke, for example, or they might have been in a road traffic accident or have conditions like Huntington's. But it's not just patients that fall into these well-defined groups that we need to worry about in terms of capacity. Some patients might not understand what we're saying to them, simply they haven't been diagnosed with a learning disability. Or it might be they might not understand English fully. Or it might be that someone who comes to see you, an emergency, who's had agonising toothache, who's not been able to sleep for the past few days, hasn't eaten, is in such bad pain and has been taking lots of medications to manage his pain, just isn't in the right frame of mind and to make certain decisions. So it's something we need to bear in mind for a lot of our patients. We will all know the legislation we need to follow in terms of capacity, which is the Mental Capacity Act of 2005. It's a big document, but there's key things that I'm going to summarise in the next few minutes that you need to remember. First is the 5 principles of the Act. The first one is really to remember, the first of the 5 principles is really easy to remember, is that you need to assume that everyone has capacity unless you prove it otherwise. And that a patient is not treated as unable to have capacity unless you've made lots of all these practicable steps that you can to help them understand, and I'll come into that later. Patients don't have capacity, don't just not have capacity if they make unwise decisions. I'm sure there's plenty of examples that you might be able to think of patients making unwise decisions against your clinical advice. That doesn't mean that they don't have capacity. They know the risks, hopefully the benefits, but they've chosen to make that unwise decision. Whenever patients don't have capacity, we need to act in their best interests. So you need to treat that patient in front of you as if they are your family member, they're your brother, your sister. And what would you do if they were someone you cared about? And finally, we need to talk about least restrictive measures. If that's basically a good way to explain least restrictive measures is that a patient might not have the capacity to consent or understand the risks and benefits, for example, of a general anaesthetic, but they might be able to for local anaesthetic. So that's much least restrictive, and then you should go for that option. How about weighing up decisions? How do you assess that? So it's really tricky, and I think it's going to be decision specific. So as I mentioned earlier on, talking about least restrictive measures, if they can't weigh up complex things like general anaesthetic risks, then that doesn't mean that they can't weigh up the risks for things that are least restrictive. If they come into your surgery and sit in your chair and open their mouth, that's implied consent. It means they understand that they're here to have their teeth looked at. But it might be they don't have capacity to weigh up decisions about whether a tooth needs saving or not. And that means they probably don't have capacity to consent. And finally, communication. It might be that you need to help them communicate what their decision is to you. So the example I gave at the beginning of the video about talking about someone who might just need a little bit more time to be able to communicate to you what they want is a good example. It could also be if they are non-verbal or select mute, they want to write things down, use sign, and use lots of non-verbal communication. So nodding and shaking their head, for example, or more other sophisticated means of communication like communication boards that some of our speech and language therapists are able to use. So that's something that could be used to help that patient communicate their decision to you. And what do you do if a patient doesn't have capacity to consent? It can make you feel quite nervous, especially if it's earlier on in your career and you're unsure about how to deal with a patient who clearly doesn't understand what you're trying to say to them or can't retain the information for long enough. Whatever you do, act in that patient's best interest. Again, one of the 5 principles I mentioned earlier, really, really important. I can't emphasize that enough. And have someone who's got your back. Get a second opinion, or a third opinion, or a fourth opinion. There's no, it depends what decision you have to make. That could be literally just knocking on the associate's surgery next door and asking, can you come and have a look at this? Do you agree with me? I think this tooth needs taking out. It could be referring them on to another service for a second opinion or getting a specialist input. If you see on consent forms, if you work in a trust or in a hospital, that if you look at consent form 4, which is the consent form that we use for patients who don't have capacity to consent, there will be a part of the form where somebody, if a second opinion is sought, they can also sign off the consent and say they agree with you. So it's important. It's also reassuring that you get somebody who also agrees with you to make sure you're doing something that's in that patient's best interest. The other thing you can do, and that we talk about, and what the Mental Capacity Act talks about, is lasting power of attorneys. So power of attorneys, this might be given for patients who at some point would have had capacity but then have lost it. That could have been because they have a degenerative condition like dementia and they've identified somebody to act on their behalf and advocate on their behalf. And there might be 2, they might have a health and a finance one. Obviously for dental we want to talk to the one who's the health one. But the important thing to remember that people fall into the trap of when we talk about LPAs is they say, oh, the LPA can consent for them. They can't consent for them. You cannot, nobody can consent on anybody else's behalf unless you're talking about children. What they do, what their role is to advocate on the patient's behalf, and so that they have an input into the decision-making process. And LPAs can be relatives. They often are like spouses or children or other members of the family, but they can also be solicitors, and I've had to deal with some of those before. And they are there to make sure that the patient's best interests are put first. And the final thing that people like to talk about with patients who don't have capacity consent is that if the patient maybe doesn't have a next of kin, or they don't have an LPA, and there's something invasive that needs doing, or there's a disagreement between the LPAs and the clinicians, is independent mental capacity advocates. Certainly this is something I wouldn't really expect a general practitioner to be really involved with. This is something as a dentist working in community or hospital that sometimes we get involved. Basically they are a completely impartial person who is appointed to advocate on the patient's behalf, and we generally don't have to involve them that regularly, but it's only in those cases that I've just mentioned. And it's okay if you're unsure. If you're not sure whether a patient has the capacity or not to consent, then getting that second opinion is important, and actually that means sometimes getting us as special care dentists involved, which I'll be talking about tomorrow. Things to take home from watching this is to make sure that you treat every patient as an individual. You assess them without any prejudgments, because you never know how much they understand until you formally go through that assessment. And it also means not just treating every patient as an individual, but sometimes reassessing patients and individual patient appointments. It might be that their dementia goes up and down, or their condition goes up and down. It might be that sometimes they're intoxicated and sometimes they're not. It might be that they're being rehabilitated from the stroke and their cognition is getting better. So it's really important that you assess appropriately at each individual appointment and get help when you need it.
Thank you, Natalie, and that was a brilliant start to this lovely three-parter. And tomorrow we'll be back for part 2. Like us on Instagram, like us on YouTube, please comment and show us your support, and if you haven't followed us already, please do. Strap in and get ready for the ride. See you tomorrow.